Hello everyone, this is Dr. Pruett. Welcome back. Today we're going to be continuing our series on cardiology and discussing cardiac conduction blocks. I don't know about you, but for me this is one of those things that's always been hard for me to remember, so even just putting this together was a good review for me. I hope that you find it helpful as well. Conduction blocks are all about electrical problems. The heart runs on electricity, and it needs that electricity to beat effectively. Just a quick review in terms of cardiac conduction. The impulse to make the heart beat comes from something called the sinoatrial node, and this is located up in the top of the right atrium, and it sends a electrical signal to the AV node. This is the atrioventricular node, named that because it sits right between the atrium and the ventricles. Still in the right atrium though is where it's located. And from the AV node, the signal pauses for just a second and then is sent down both the right bundle branch and the left bundle branch to make each ventricle contract and send blood to where it needs to go. Now, each of these areas where the electricity has its effect, whether it's the sinoatrial node or the AV node or the ventricular, the branches in each of the ventricles, they have intrinsic conduction rates. And what this means is that the heart, as amazing as it is and as vital as it is to sustaining life, it has backup mechanisms built into place where if for whatever reason, say the sinoatrial node fails, the AV node is kind of programmed to take over. And then is even a further backup, if the AV node fails, the ventricles have some inherent conduction activity as well. Now, just like most backup systems, they're not perfect and they have some flaws and they're not quite as good as the primary choice, but they can work for a short amount of time in order to sustain things until things can get fixed. So what we can look for is signs on the 12 lead that show us where the cardiac conduction is coming from. So if we see a P wave, we know that this is coming from the sinoatrial node. This will cause a narrow QRS with the rate usually between 60 and 100. So the width of the QRS and the rate of the beat will usually give us a clue as to where that beat is originating in the heart. The AV node, as the primary backup system if the SA node fails, also has a narrow QRS and typically has a rate between 40 to 60. And the reason that that QRS is narrow is because it's still following the normal conduction through the ventricles. Where the QRS starts to get wide is when the ventricles have to take over. And this is a really ominous sign. It's the body's last-ditch effort at keeping itself going. So if you see a ventricular rhythm, typically you'll see a wide QRS with a rate between 20 and 40. That's as fast as it can possibly go. So just looking at the rate and the width of the QRS will give you a really good clue as to what's going on in the heart from an electrical standpoint. Now here's just another depiction of more of the cardiac electrical activity. We talked about the sinoatrial node. You see that here. It sends a message across both of the atria to the AV node, and as it sends that electrical conduction signal, the atria contract. And what you see that represents that on your 12 lead is the P wave. So the presence of P waves tells you that the sinoatrial node is working and it's sending its message to the AV node. Now remember, the signal takes a small pause at the AV node before it sends the message to the ventricles, and the ventricles contract. Well, the ventricles are big, strong muscles that have to send blood to the rest of the body, so they contract with a big force. There's a lot more muscle tissue down there. There's a lot more electrical conduction fibers. And so as you see the ventricles contract, what you'll see is the QRS. And that's why this is, when you look at a 12 lead, the ventricular contraction or depolarization is usually the biggest vector on the 12 lead because that's the biggest muscle as it's contracting. So that's why it looks the way that it does. And like we discussed before, if that signal for the ventricles to contract is coming from the AV node, it's going to be a nice narrow QRS. And what that tells you is all the pathways are working like they should be. If it starts to widen out, it may suggest that the signal is coming from below the AV node from that inherent ventricular backup rate. And then the next wave that you're looking for on the EKG is this T wave. And what the T wave tells you is that the ventricles are repolarizing. So they're recharging themselves. Sodium and potassium are moving in opposite directions so that they're ready to beat again. So just quick review. P wave, atrial depolarization from the sinoatrial node. QRS can either come from the normal conduction or any of the backup areas, just dictates the width where it's originating from, but it indicates that the ventricles are depolarizing and contracting. And then the T wave is repolarization. I know this is a lot of information and EKGs can be really difficult. I want to just emphasize that consistency is key when you're looking at 12 leads. You really want to look at as many as you possibly can. And then one thing that you can really do to help yourself is read an EKG the exact same way every time. So as you're handed a 12 lead, this is the way I do it. I do 5 things the same way every time. First thing I look for is this sinus rhythm? Meaning, is there a P wave before every QRS? Is that beat originating from the sinoatrial node? And is it conducting through appropriately? Next, I look at the rate. Is it fast or slow? And is it regular or irregular? Then I ask myself if the QRS is wide or narrow. Now that gives me an indication to how healthy the ventricles are and if they're responding to the electrical signal like they should. Next, I look at my intervals and axis. Mostly the interval I'm concerned with emergently is the QTC, because this can lead to spontaneous torsades if it's not addressed. And then I look at the axis. Lastly, I look at ST elevation or depressions. And the reason I save this for last, even though some people would argue that it's most important, is if you're very disciplined in the way you look at these 12 leads, you're going to pick up a lot more subtleties and very important findings than if you just go straight to the ST segments first and then forget to look at the smaller details that can have important consequences. So try to do it the same way every time. This is the way I would suggest. It's 5 easy steps, and do it the same way every time. Look at as many 12 leads as you can and try to practice. So speaking of practice, let's look at a 12 lead here, and we'll do it with my 5 steps. So first you want to look at the rhythm. Is there a P wave before every QRS? And the easiest place to find the P wave is usually lead 2, and I do see a P wave before every QRS and then a T wave. You can look in V1 as well. P wave, QRS, T wave. Okay, I do see P waves. I would call this a sinus rhythm. Next, is it fast or slow? So you can use the rule. I won't go over all the rules here, but so I would call this normal sinus rhythm. It's not fast, it's not slow, it's just right. The QRS is regular with a normal rate, and you can march out the distance if you want to. You can measure the distance between the QRS vectors and see if they march out and they're equal with every beat. Is it narrow or it's wide? I realize that this example doesn't have any numbers up on the top. It's totally okay if you have a computer that's measuring those intervals for you to look at the top, but you can also use your eyes and train your eyes to recognize wide or narrow. I would say just by looking at this QRS vector that it is narrow. And then intervals and axis. I mentioned that the one interval I'm most concerned with is the QT. You want to see, if you're trying the eyeball test, you can see if that T wave falls to the left of midline between your QRS vectors. In this case it does, so I would not be concerned about prolonged QT. And then the axis we'll talk about a little bit later, but this is a normal axis looking at leads 1 and AVF. Both of the vectors are up, which is a positive sign. And lastly, I look at my ST segments. I'm looking for any ST elevation or ST depression, and that is the baseline between the QRS, where it comes back to the baseline there, and the T. And all of those look to be normal to me. So I would call this normal sinus rhythm. So we start to move into conduction blocks, where we're talking about hearts that have difficulty with their electrical wiring. We're going to progress through some pretty benign rhythms into more severe rhythms. So we just talked about normal sinus rhythm and what that looks like with a P wave before every QRS. Next one is first degree heart block. This is where your PR interval, the distance between the P and the QRS, is longer than it should be. And what that's telling you is that the impulse from the sinoatrial node to the AV node is just taking a little longer than average. Doesn't necessarily mean it's bad, it's just long, and it's something to take note of. Then as we progress to more severe conduction disease, there's a 2nd degree heart block type 1. This is where your PR interval progressively increases. So you see a P wave here right next to the QRS, and then it gets a little bit longer, and then a beat is dropped. That's a type 1. Whereas a type 2, you have a pretty constant PR interval. So your P, QRS, P, QRS, P, QRS. But in between you have these P waves where those beats are not conducted, and they're just randomly dropped. It doesn't have to be like this one where every other beat is dropped. It can be randomly dropped as well. But that's a signal of a sick conduction system. And then ultimately you get to 3rd degree heart block, which can be very bad for some patients and typically needs some sort of intervention from a cardiologist to help the heart beat more efficiently. But this is where you have complete dissociation between the atriums and the ventricle. They're just not talking to each other for whatever reason. So here you see P waves and a QRS, but here's a P wave and no QRS, P wave. That P wave looks like it's in the T wave. The P waves tend to march out at a regular interval, but you can see a very wide QRS here where essentially the ventricle is having to take over. Remember that intrinsic ventricular rate that's between 20 and 40 and a very wide QRS? That's what's happening here. So you see that the P waves are not talking to the ventricles. The ventricles feel like they're having to take over on their own, and they're causing a bradycardic rhythm that's very wide. And that's called AV dissociation. So we'll look at some examples of these. So 1st degree AV block, pretty easy, pretty benign. All it means is that the PR interval is more than 3 small boxes or greater than 200 milliseconds on the 12 lead. You still have a P wave before every QRS. It's just that length is a little longer than normal. And for whatever reason, the communication between the SA node that causes ventricular depolarization is just a little bit slower than it should be. There's really nothing to do about this. It's benign, and usually patients don't even know they have it. Here's what it looks like on a 12 lead. Again, you see the P wave, and then it just takes longer than it should to get to the QRS. But there is a P wave before every QRS, and the QRS is normal. So things are conducted like they should be. It's just a little bit of a delay. Whereas in a 2nd degree type 1, this is where you have the progressively lengthening PR interval. So here's your P wave, QRS, P wave, QRS, and then a dropped beat. And you see it's getting longer every time. Now this can cause sometimes symptomatic bradycardia. So the theme of all these blocks is what's going to happen if the conduction is not working as it should. You're going to end up with a bradycardic patient. So for all of these blocks, it's important to recognize them, but really at the end of the day, you just need to be ready to treat bradycardia. So here is the PR interval, a little bit longer, and then it disappears. But the heart starts over and then does it again. So here's a 12 lead with a 2nd degree type 1 AV block. This is the progressively lengthening PR interval. You see a short one here, a little bit longer here, even longer there, and then boom, the beat's dropped. That's 2nd degree type 1. Again, if treat based on what you're seeing your patient doing, but if the patient is looking ill, then be ready to treat for bradycardia. Now, this is interesting. Here's another 2nd degree AV block type 1, and this is where your self-discipline becomes important. Remember those 5 things that we do every time we look at a 12 lead. You ask yourself, is there a P wave before every QRS? The answer is yes. So technically you have a sinus rhythm, but what is that P wave doing? As you look at your intervals and your axis, you can see shorter P wave here, longer P wave here, and then a dropped beat. And then it repeats, short, longer, 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 dropped. Now, there's something that's inherently obvious on this EKG that your eyes are going to want to jump to right away. And that's fine, because this is definitely a cardiac emergency. But realize, if you just focus on the massive ST elevation in your inferior and some of your anterior leads with the reciprocal changes in your lateral leads, for the STEMI, you might miss the AV block that's going on too. Now there's an important learning point here, is that remember, when you're having a STEMI, that's an occlusion of muscle and electrical conduction in the heart. So potentially, especially important for the inferior MIs, if you look at 2, 3, and AVF, and you see your ST elevation here with some inversion in AVL and depression in 1 in AVL, that involves the right side of the heart most of the time. And remember, your sinoatrial node is located in the right atrium, so it's not uncommon that your inferior MIs are going to affect your sinoatrial node or your AV node, and as a consequence of an inferior MI, you can absolutely have a patient who develops conduction blocks as well, which further complicates their picture. So anytime I see inferior ST elevation in my mind, I'm always preparing for some sort of bradycardic or conduction block sequelae from that. Okay, moving on to second degree AV block type 2. This is where you have the constant PR interval with the randomly dropped QRSs. And sometimes they're not so random. Here you have an example of 3-to-1 conduction. So you have a P wave QRS, a P wave no QRS, P wave no QRS, and then your third one is conducted. So that's 3 P waves to 1 QRS. That still results in a pretty bradycardic patient. So I wouldn't be surprised if this one was symptomatic. And then you can also have a very unpredictable pattern where some P waves will get through and others won't. Now this is a pretty sick conduction system and a heart that's really struggling, and I wouldn't be surprised if these patients were very symptomatic because the rate of conduction that's actually getting through to cause the ventricles to send blood to where it needs to go is actually very slow. This can quickly develop into third degree heart block as well. So here's an example of second degree type 2. Remember, this is the regular PR interval. It's the same distance between every P wave and QRS. It's just that they're randomly dropped. So what you want to do in this one is just prepare yourself for symptomatic bradycardia. This 12 lead here isn't so bradycardic, but you really just want to base your treatments on what your patient looks like and anticipate this getting worse. Realize that this is a pretty sick conduction system. So if we look at this 12 lead, here's P, QRS, P, QRS, P, QRS. Looks like this one's doing pretty good. P, QRS, P, QRS. And then all of a sudden over here, it starts to drop beats. And this might be easiest to pick up on a rhythm strip, not necessarily a 12 lead, but 12 leads are still important because they give you a look at all the different aspects of the heart. Here's another example of a type 2 second degree. Again, you're looking for P's before every QRS. I think here's a P wave with no QRS, P, QRS. Here's the idioventricular beat. This is just a heart that looks like it's confused, right? You have a P, QRS, here's your T wave, and then you have a P, no QRS, here's the P that's conducted, a P that's conducted, and then a dropped beat over here. So it's pretty irregular. You can see the random dropped beats. It can make it look like AFib or like an irregular rhythm, which it really is, because unpredictable pattern for beats being conducted through the ventricles. And here's third degree heart block. This is AV dissociation, where the ventricles and the atria are completely not talking to each other. And what you see here is P waves that march through at a very regular interval. So the sinoatrial node is doing its job and beating at its normal rate. However, for whatever reason, the AV node is completely stopped communication with the ventricles, and the ventricles feel like they need to take over. So you see a wide QRS at a rate of that 20 to 40, so bradycardic rate, and the ventricular rate is very regular as well. This will result in a bradycardic rhythm and usually a pretty symptomatic patient. Here's a 12 lead with AV dissociation. Again, you're seeing I just starred some of the P waves here. Here's a P, P, P. They're marching out at very regular intervals, and sometimes they can be buried in the QRS, so they're hard to find or they change the morphology. But if your eye starts to pick up on it, you can see how they march out and predict where they should be. And then you see that your ventricular rate, this one is not so wide of a QRS, but it's still marching out at its own rate. Here's a good 12 lead of complete heart block. Again, these P waves are fairly spread out here, and some of them are a little subtle and more hard to see, but if you follow, you can and some of them get buried in the QRS. But you see a very wide QRS, a bradycardic rhythm, and this is a patient with a sick heart that you need to be ready to treat for bradycardia and pace if you need to. Chief Ortiz gave me this memory aid for conduction blocks that he learned in paramedic school. I found it pretty helpful. If the R is far from P, then you have a first degree. Longer drop, then you have a winky Bach. If some P's don't get through, then you have a Mobitz 2. If P's and Q's don't agree, then you have a third degree. If that helps you, I know sometimes poems or music help me remember things too. So whatever you need to do to help remember these, really at the end of the day, just recognize symptomatic bradycardia if you have a patient with a block and be ready to treat that. So when we're talking about bundle branch blocks, this is another sort of sick conduction problem in the heart, and it's not so focused. Most of the ones we just went through were focused between the sinoatrial node and the AV node. This is a little bit bigger of a problem because it's involving the bundle branch blocks that help the ventricles depolarize. Now this is a big deal because these are the things that need to work because they're telling the ventricle to contract and send blood where it needs to go. And if these are diseased, then you're going to have a heart that's not beating as efficiently as it could be. So things that suggest that you have a bundle branch block, these are the three things that I look for when I'm trying to decide if a bundle branch block is present. They will always have a wide QRS, remember, because that's a beat that's originating, or a problem that's originating from the ventricle. So it will make your QRS wide, which is greater than 120 milliseconds. It will still have P waves. You're still getting a signal from the sinoatrial node usually. So it's coming from a supraventricular origin. And then your clue to this will be a supraventricular origin with a wide QRS will tell you have a diseased bundle branch block. And then I look at V1. And if the majority of the QRS vector is up in V1, then I know that that's a right bundle branch block. And if the majority of the vector is down in lead V1, then I know I have a left bundle. It's that simple. You have a wide QRS with P waves present. You can look at V1 and ask yourself, is it up or is it down? And then you know which side is diseased. So let's start with the left bundle branch block. For me, this can look very much like a STEMI, and that's okay. What this should tell you is you have a very sick heart. Your left bundle sends conduction to the left ventricle, which is the strong side of the heart that sends blood to the rest of the body. And if this is diseased, this means that your heart is probably going to be diseased. So things that can cause this could very well be a heart attack. A STEMI can be a result of or cause heart failure. It can be a result of hypertension, left ventricular hypertrophy, valvular problems in either the aorta or the mitral or tricuspid valves, and then infection in the heart or myocarditis can cause it as well. Now, important to note with the left bundle branch block is that these patients have a 7-fold increased risk of heart failure and double the risk of coronary artery disease. So if you have a patient with a left bundle and they're telling you that their chest hurts or they can't breathe, you need to respect that because this is a very sick heart at baseline. And it's really impossible for us to tell in the field whether this is a new left bundle branch block or if it's old. So I treat these patients very gently, realizing that they could become potentially very ill if they're not already. So when you see a left bundle, realize that that's a sick heart. Here's a look at a left bundle on a 12 lead. And at first glance, if you're just looking at those ST segments, it might look like a STEMI, right? But we're going to be disciplined about our approach to reading it. So the first thing we look for is P waves before every QRS. And do we see those? Absolutely yes. Here's a P, QRS, P, QRS, P, QRS. Again, lead 2 will be usually your easiest place to see those, P, QRS. All right, so we know that sinus rhythm. It's a little bit fast, like right at 100, 300, 150, 100, regular, but the QRS is wide. So we have a sinus rhythm with a wide QRS, and now I'm starting to look at my intervals and axis. I do have left axis deviation, which we'll talk about in a minute, and the intervals are kind of hard to tell because the QRS is so wide. When I look at my ST segments, I do see ST elevation in leads V1, V2, V3. I don't see any depression anywhere though, so no reciprocal changes. But since I've been clued into the fact that I have P waves present and a wide QRS, I'm going to look in V1, and the majority of that vector is down. So what does that tell me? That I have a left bundle branch block. So this is a pretty typical appearing left bundle branch block 12 lead. Here's another one, and your eyes will start to recognize it. That's why I encourage you to look at as many of these as you can. But again, if we read it disciplined, we have a P wave before every QRS. We have a wide QRS, and if you need to, it's okay to look up here, right? Your QRS here says it's 146, so that's greater than 120. You look at lead V1, it's mostly down, so you're thinking, okay, maybe I have a left bundle. I do. You still have some ST elevation in V1, 2, and 3, and not real sure about reciprocal changes here, but I would call this a left bundle branch block. Now the question frequently arises, can you have a STEMI with a left bundle branch block? And the answer is absolutely yes. Remember, these are sick hearts at baseline, so they can absolutely have coronary artery disease. And sometimes the STEMI can be hidden inside the left bundle, and it's hard to find. Now there are some things called Sgarbossa criteria that tend to help identify STEMI and left bundle. You don't need to memorize these. I frequently have to look them up myself. But really what you're looking for is ST segment elevation greater than 1 millimeter in V4, 5, 6, or AVL on those lateral leads, or ST segment depression in V1, 2, or 3, or ST segment elevation greater than 5 millimeters in any lead if you have discordance, meaning that the QRS vector is different than the T-wave repolarization direction. Now, from a pre-hospital standpoint, it's important to know that those exist, but really remember that left bundle is a sign of a sick heart, and we have no way to tell if that's old or new, so a left bundle could be a STEMI equivalent. And if you have a patient that looks pale and diaphoretic and has a history of hypertension and smoking and likely coronary artery disease, you need to treat that patient like this could be a STEMI, give them aspirin, and get them to the hospital as quickly as possible. Now here's a look at a left bundle branch with a STEMI. So you still have your P wave before every QRS. You have the wide QRS, a vector that is mostly down in V1, so you have a left bundle. But here you're looking at, remember, we have greater than 1 millimeter ST elevation in V4, V5, where the QRS and the T wave are both going up. And then you have depression over here. So you have elevation laterally, depression inferiorly. You could call this a STEMI with a left bundle. Moving to right bundle branch blocks, I feel like these are a lot more frequent. We see these a lot in the pre-hospital setting, at least at the 12 leads that I look at. This is the bundle coming off the AV node through the bundle of His on the right side of the heart. And this one you might hear referred to as rabbit ears. But we'll look at this one in our systematic fashion. P wave before every QRS. Our QRS is 164, so this is a wide QRS. Is it fast or slow? We have a rate of 82, so it's normal. It's regular. QRS is wide. I have a normal axis, and the intervals generally look okay. My QTC is the one I look at. It's 442. Next thing I look at is my ST segments. In general, they look okay. And over here in V1, the majority of this vector is up, and I'm starting to see those rabbit ears in V2 and V3. So what I have here is a right bundle branch block. And here's another example. You can see that we have P waves. This looks like almost changes in the interval here, but you have P waves before QRSs. You have a majority of a vector that's up, and your QRS is 154, so you have a right bundle branch block here. But what we're seeing here, the thing to point out, you have a 67-year-old patient with a heart rate of 113. So remember, when patients are tachycardic, that's essentially like they're giving themselves a little stress test. And this is a patient who, for whatever reason, I don't know why they're tachycardic, but they're failing their stress test. You can start to see signs of cardiac ischemia on this 12 lead. So the ST segments are depressed in V4, V5, and V6. And that's showing that on that lateral side of the heart, that piece of heart is not getting the blood flow that it's demanding and can't keep up with the demand for the muscle to work like it should. So sometimes tachycardia can cause stress on a heart. And just like we talked about STEMIs in left bundles, you can also have STEMIs in right bundles. These are a little bit easier to recognize here. This one is not subtle. You can see ST elevation and AVR. You see depression in 1, 2, 3, 4, 5, 6. There's just widespread ST depression everywhere with elevation and AVL. Now what this is left main disease, and you have the 1 millimeter of elevation in AVR with widespread ST depression everywhere else. Now, quick note about axis determination. If you make put your thumbs in front of you, and your left thumb is going to do what lead 1 does, and your right thumb is going to do what lead AVF does. So if you look at this EKG, look up at lead 1. Remember, this is your left thumb, okay? Look at AVF, and this is your right thumb, and you're looking at where the QRS vector goes. So this one is mostly up in 1, so your left thumb is going to be up. AVF is mostly up, so your right thumb is going to be up. That's 2 thumbs up. That means you're good to go, and your axis is normal. You see that? Left thumb is up, right thumb is up. This is a normal axis. Now here's one with left axis deviation. Your left thumb is lead 1. Your right thumb is AVF. So your left thumb is up, your right thumb is down, and whichever thumb is pointing up is the way that your axis is going. So you have left axis deviation because your left thumb is up. Now opposite of that, if you look at this 12 lead, your left thumb is mostly down, so you have most of the vectors going down, but AVF is mostly up. So your right thumb is up, which means you have right axis deviation. Now the reason this is important is because, I'll just jump right to it, but here we have a right bundle branch block. You have a wide QRS with P waves present, and you're up in V1. That's a right bundle, correct? Look at your axis here. Your thumb is up in lead 1, right? Your left thumb is up. Your right thumb is down for AVF. So what axis do we have? We have left axis deviation. So we have a right bundle with left axis deviation. And what that tells us is that we have bifascicular block. Now look at this conduction system here. We know, based on that last 12 lead, that we have a right bundle branch block, right? So the big branch going to the right side of the heart is not working correctly. But then with our axis deviation, remember your left side has the anterior and the posterior fascicles. With the left axis deviation in the setting of a right bundle branch block, this left anterior fascicle is not working either. So 2 of your 3 conduction highways that are telling the ventricles what to do are broken. So it's a very subtle finding, but very important, because bifascicular block tells you have a pretty sick heart. Now here's another important 12 lead. Now what do we see here? We see a left bundle branch block. We've got P waves before the QRS. We've got a wide QRS with the majority of it down. This is a left bundle branch block. But then take a look at your axis. Your thumb is down in lead 1, right? Your left thumb is down. Your right thumb is up in AVF. So what do you have? You have right axis deviation. Well, this is a left bundle branch block with right axis deviation. What does this tell you that you have? This is trifascicular block. This is an incredibly unstable, sick heart. And you can pretty much tell that by looking at this 12 lead, but being able to determine your axis is going to help you articulate that a little bit more. So looking at where your problems are in this 12 lead, you have a left bundle, which means that both your anterior and your posterior fascicles are not working. And then with your right axis deviation, it means there's a problem with your right bundle branch as well. So that's 3 fascicles or trifascicular block. Now I know this is a lot to cover. I just want to emphasize that the more you look at, the more you're going to start to recognize and pay attention to those details and be consistent and read them the same way every time, and things will start to catch your eye. I want to emphasize too that if you're just getting 4 leads, that's only giving you 25% of the picture. So go ahead and get a 12 lead on any patient you think might be having anything related to cardiac problems at all. And if you have any questions, please contact your 7-8.